So the topic today is on hip preservation in the athlete's hip, and it's actually on the birth of a field, and I'll explain what I mean by that. My disclosures are listed with the American Academy of Orthopedic Surgeons. So in this talk, I'm going to talk about the evolution of a field and how a field is born. We'll talk about the first mountain to climb, which is how to diagnose a certain spectrum of pathology. The next mountain is what can we treat? And I'll tell you a tale of three journeys that I've been a part of in figuring that out. And then a little look back on what have we learned. Before I get to that, a word on mentorship. Mentorship is a two-way street and you get what you put in. You have some wonderful mentors at University of Rochester, like Brian Giordano and many others. And in your residency training, I would just like to put forth a recommendation to take full advantage of that, take advantage of the opportunity to have mentorship and understand that it is a two-way street. Maybe something that I didn't understand when I started residency, and I came to understand it over the course of my training. Think, how can you help your mentors? What can you do for them? What do they need to get done that you can help with? And when you think that way, then they think the same way in return, and they want to help you back. So think of it as a two-way street, not that you're entitled to their help or entitled to their mentorship, but rather that you can earn their mentorship by helping them one way or another. And as I learned that in my own training, it helped me develop some wonderful mentors. I had some great mentors over the course of my training, and actually it started a little earlier. I had a great mentor in college. I played basketball through college at Princeton, and our coach there was probably more famous than any of the players. Pete Carrill was his name. He died recently, and his legacy that he left was one of having brought Moneyball to basketball. He brought data and thinking statistics to basketball. He eliminated the mid-range jump shot basically 30 years before the NBA did. And he was a great mentor to me, and somebody who inspired in me the spirit of innovation, not in medicine yet, but at least in basketball. And as I did make my career into medicine, in sports medicine, he's somebody who rung in my head, making me ask the question, is there room for growth? Where can we innovate? Where can we get better? This is me in my younger years here with a much taller opponent at Madison Square Garden. That's Manute Bol, who also has passed, but was a full foot taller than me. So that's my metaphor for room for growth. I did my sports medicine training at the Carl and Job Clinic, as did Dr. Giordano, and had some other great mentors there, not the least of which was Frank Job. Frank Job is certainly a famous orthopedic surgeon, and if I'm speaking to a layperson and they haven't heard of Frank Job, they've probably heard of Tommy John. Tommy was a famous pitcher in the 70s who tore his ulnar collateral ligament in his elbow. And that was an injury that had not been well described or described at all. There was no known treatment for it at the time. And Job literally had to think of something. And he had once seen a hand surgeon harvest a palmaris tendon in the wrist for something else entirely, and thought maybe he could harvest the palmaris tendon and weave it into a ligament in the elbow. And he did that in Tommy, and Tommy came back and had more wins after that surgery than he'd had before. So that was an innovation that changed the face of baseball medicine for sure. There are 1/3 of pitchers in the major league today have a Tommy John procedure. And it changed sports medicine as a whole. It was one of the first advances that really took an injured player that couldn't play and got them back to being able to play as good or better than new. So as we think about how to innovate, and as I thought about how to innovate in sports medicine, one question that came to me was, why do we not think of the hip the same way we think of the rest of sports medicine? In other joints, for the last 30, 40 years, the principle of sports medicine has been restoration of anatomy. And in the shoulder, that has meant labral repairs or anatomic cuff repairs. In the knee, anatomic ACL reconstructions. And in the hip, pain had traditionally been diagnosed as early arthritis. And so if a young patient came into the doctor with hip pain, they said you have early arthritis, you might eventually need a total hip replacement, and not much we can do for you until then. Well, we live in an age where that advice is not well received, and athletes want to come back and play their sports. People are staying active longer than ever before. So even at middle ages, people are not happy with that advice and want to have a fix. So a typical patient's response to that advice is seen here. So the birth of a field. The birth of a field starts with an evolution of understanding. And fortunately for us in the hip, we had a little bit of a roadmap, a recent roadmap really, from the shoulder to look at how a field is born and how understanding evolves. So if we look at the shoulder, in the 1960s, they thought everything was osteoarthritis. If you had a shoulder pain, you got a sling, maybe you got a cortisone shot. That was about all that was done for you. In the 1970s, Charlie Neer described impingement in the hip, in the knee, in the shoulder, hip, knee, shoulder. Charlie Neer described impingement in the shoulder. And for a good decade there, everything was impingement. At this point, if you came in for shoulder pain, you got a cortisone shot. If you got surgery, you got a subacromial decompression. So impingement was the catch-all diagnosis. But some smart surgeons realized that some findings did not fit. And that led to the discovery of other problems, like all the things we know so well and treat so well today: rotator cuff tears, labral tears, biceps tendon tears, AC arthritis. So this was the evolution of a field in the shoulder, and it happened over the course of 2 or 3 decades. So in the hip, in 1999, the concept of labral tears came into the literature. Joe McCarthy published on them first and the concept was it was a watershed lesion. They thought that there was an area of lack of vascularity. In 2001, Gans described FAI. Reinhold Gans in Switzerland described femoroacetabular impingement. And there again, for a decade or so, everything in the hip was diagnosed as impingement. Previously, everything was arthritis. Now everything pre-arthritic was impingement. But that was probably too simple. And again, some smart surgeons realized that some findings did not fit. And that has led us to seek to explain these other findings and identify and understand diagnoses, including microinstability, iliopsoas impingement, gluteus medius tears, rotational deformities, and a plethora more that account for a lot of non-arthritic hip pain. So all of this is a paradigm shift. What is a paradigm shift? Paradigm shift is a way of looking at something differently. Same thing we've been looking at, but looking at the same thing differently than we've been looking at it before. And for us at American Hip Institute Research Foundation, looking at the hip as its own field has been a paradigm shift. Understanding that we have been living through the birth of the field. This is a paradigm shift, and birthing that field into its own field worthy of its own fellowship, its own journals, its own conferences, that has been the paradigm shift that we have been a part of. So at American Hip Institute, there have been 3 major areas of focus and innovation. The first has been hip preservation and arthroscopy. The second has been robotic procedures. And the third has been hip resurfacings and other alternatives to arthroplasty. In this particular talk, I'm going to focus on hip preservation and arthroscopy and focus on the birth of this field. So the first mountain that we had to climb was, how do we diagnose these problems? And this was truly a mountain to climb. Now, some of our patients look like these guys. And this is one discipline, and certainly these guys get some attention for their care. Some of our patients look like these folks. You see here a female athlete, gold medal winner, an aging athlete who you all know. Some of our patients look like these folks. This is a microinstability case on the left, and a much older athlete on the right, old enough that his game playing pictures were in black and white. So The diagnostic dilemma that we're faced with across all of these patients, this quite a big range of types of patients, is that 60% of athletes undergoing arthroscopy were initially misdiagnosed in an early study by Thomas Bird, and they stayed misdiagnosed for an average of 7 months. Surgery on the wrong site had been recommended in 17% of patients. So these are staggering numbers, and obviously we want to do a lot better than that. Now, why is it so difficult to diagnose? I think in part because our brains do not do a very good job of localizing where the symptoms are coming from when they're coming from the hip. It's right in the middle of the lumbar plexus innervation, and so it shares innervation. The hip shares innervation with a lot of other different body parts, and as a result, we can feel it in a variety of different places, and that leads us to common misdiagnoses such as groin pulls, hip flexor problems, muscle strains, sciatica, bursitis, and hernias. All of these things are common misdiagnoses when actually the problem is coming from the hip. So we've all seen people who have had these misdiagnoses, who have had a hip problem that was diagnosed as a spine problem or a hernia or any other number of things. I've seen people who have had hernia surgeries because they had groin pain. I've seen folks who have had laparotomies or laparoscopies for what was thought to be endometriosis, when in fact it was a hip problem. I've even seen a man who had a spermatic cord nerve stripping because he landed in the urologist's office and had groin pain. And frankly, I don't really even know what a spermatic cord nerve stripping is, but I know I don't want one if I have a hip problem. In assessing the hip, the first question that I ask is the pain coming from the hip or is it coming from something else? And we never want to make the same mistake, right? We don't want to misdiagnose something as the hip when in fact it's a spinal radiculopathy or a hernia or a sports hernia or a muscle strain. The second question, if it's coming from the hip, is it intra-articular, such as FAI or labral tears, or is it extra-articular, such as internal or external snapping hip, trochanteric bursitis, or gluteus medius tears? And if it is intra-articular, can the problem area of the hip be localized by exam? So can we find specific areas of impingement, specific provocative tests, or instability tests? So I come back to one of my mentors, Frank Jobe. One of his favorite lines, which I think is very appropriate here, is that the diagnostic gold standard is still the history and physical. The MRI helps convince the patient, not the physician, that there is a significant injury. And I think never was this more applicable than in the hip, where there is a lot of noise on the imaging, there is a lot of noise in the patient's symptomology, and we really have to examine the hip well in order to come to a diagnosis. So physical examination of the hip, that said, is uniquely challenging. This is not how you do a physical examination of the hip. This is how you do a physical examination of the hip. We always start with bilateral range of motion. This is very important. We can find asymmetries in the motion between left and right side if we do this. And we need to have a very replicable way of doing it. It might sound simple to check range of motion, but it's actually not, because there's a lot of degrees of freedom around the hip and the knee. So the way that I check range of motion is with the patient supine, with one hand on the knee as the hip is 90 degrees flexed. And that you can see on the left-hand picture, my right hand is on the knee, keeping the knee directly above the hip. So I don't let it go into abduction or adduction. And then my left hand is rotating by holding the ankle, and I can measure the angle of the tibia relative to the angle of the midline of the body, and that's my internal and external rotation. Very important to do this in a consistent way. If you let the knee go a little in or a little out, it'll dramatically change your measurements of range of motion. So consistency here is key. If you are not going into anything related to hip at all in your career, if you're going into spine or hand or shoulder or sports or anything else, I would implore you to remember this one test. This is the impingement test. This is flexion, internal rotation, and adduction. And the reason I'd implore you to remember the impingement test is because it is probably the most sensitive test for hip pathology on our physical exam. and one that is worth doing for any patient who has any pain anywhere in the lower extremity, whether it is in the back or buttock or groin or down the leg or knee or foot or ankle. Do an impingement test so that you rule out pain that is radiating from the hip. So flexion, internal rotation, adduction. Everybody has a different endpoint. A ballerina, you have to go a lot further than you do in a football player. So take them to their endpoint of these three motions: flexion, internal rotation, and adduction, and you can rock them around in that endpoint. Lateral impingement. This is abduction, and you can add a component of internal rotation. Posterior impingement is extension and external rotation. Long roll is specific, but probably not very sensitive. And there are a litany of other tests which are very valuable as you dig deeper into this field. Always assess gait, look at Faber test, anterior apprehension for instability, strength testing. Tenderness is important, but very non-specific. And so I've listed here a bunch of places you can look for tenderness, but remember Hilton's law, the pain coming from a joint is felt in the muscles that cross that joint. Well, there are 27 muscles that cross the hip joint, and a patient may feel pain in any of those. So tenderness anywhere around the hip is important, but not very specific. As we look at our radiographic analysis, learn these angles. Even if you're not going into anything related to hip, you'll need them for the boards. The lateral center edge angle, we use a horizontal line as a reference, the horizontal line between the centers of the femoral heads, and then measure to the most lateral point of the sourceal and subtract 90. And that gives you your lateral center edge angle. The reason we use a reference off a horizontal line is in case the pelvis x-ray is a little bit tilted one way or another, but the patient is not lying in a perfectly aligned way on the x-ray table. That allows us to account for it. Acetabular inclination. Here again, we reference off of a horizontal line and measure the angle of the sourceal. This is also known as the tonus angle. Crossover sign. This is a sign that has gotten a lot of attention on boards and such. This is the crossover between the anterior wall and the posterior wall, and it is a sign of acetabular retroversion. Crossover sign can be quantified as to how far down between the superior acetabulum and inferior acetabulum it crosses over. And here I would describe this as about a 45% crossover sign. Ischial prominence. Ischial prominence is another sign of acetabular retroversion, and we can measure that relative to the iliopectineal line. And alpha angle measurement. This is a measure for cam impingement. In the alpha angle, we draw a circle and we see where does the femoral head actually leave the circle. Then we make a line parallel to the neck and another line to the spot where the head loses sphericity and leaves the circle. And that is our alpha angle, which is here 79 degrees. Offset. Offset can be measured between a line parallel to the neck and the cam lesion, and here I would say this offset is 0 millimeters. Some would measure the offset further down on the neck and measure it at 8 or 10 millimeters, but I would argue that that's not where the impingement occurs, so we measure it at the same point as the alpha point. So here that would be 0. Advanced imaging. MR arthrograms have been very valuable in diagnosing intra-articular hip pathology. Some centers have produced very good non-arthrogram MRIs, non-contrast MRIs, but I would say a majority of centers and MR arthrogram has been shown to produce greater specificity and sensitivity in detecting intra-articular pathology. It is very important to note that not all MRIs or MR arthrograms are created equally. Not all centers perform the same MRI sequencing. There's a lot to this. Patients don't know that. Patients think an MRI is an MRI, and we all know that's not true. So very important to work with your radiologist at your center to develop the protocols, to develop the sequencing and get good images of the hip. And 3D CTs. 3D CTs can be very helpful in understanding the three-dimensional bony anatomy, particularly in surgical planning, and particularly early in your career in hip preservation. I find they can be very helpful in our training for our fellows. Many orthopedic surgeons have taken credit for the quote, "The eye sees only what the mind knows," but actually it was Plato who said it first, a long time before there were orthopedic surgeons. And I think the quote is apt to describe the concept that diagnosis is critical. This hunter here is not finding what he is looking for because he is not looking in the right places. And we must look in the right places if we're going to find the pathology of the hip. So that was the first mountain, diagnosing pathology in the hip. The second mountain is what can we treat? And figuring out what we can treat and what we could treat successfully in the hip has been quite a journey. And I'm going to tell you actually 3 of the little journeys that I've been a part of at the American Hip Institute in figuring out what can we treat. The first journey has to do with anatomic restoration of the labral seal. The second journey has to do with accuracy and treatment of the FAI. And the third journey pertains to recognition and treatment of instability. Another quote for you, which is apt, from Thomas Edison: "I have not failed, I've just found 10,000 ways that won't work." I feel like I have too, and I'll try to share some of them with you as I share these journeys. So the first involves the principles of restoration of the labral seal. And the first thing we had to understand before figuring out how to repair it was, why did it matter? And we've come to understand that the labrum improves hip stability by increasing the articular surface by 22%, the acetabular volume by 33%. It acts as a seal. It seals the ball in the socket and creates a negative pressure environment that provides stability. It also maintains the articular fluid film, which distributes the load across the hip joint using hydrostatic load distribution. And it prevents lateral displacement and distraction forces. It also plays a role in load bearing. So the impact of the femoral head on the acetabulum is increased by 40% without a labrum. Put all these things together and we come to understand that the labrum is chondral protective. It is a very important structure in allowing our cartilage to stay intact over the course of our long lives. Here's a video that we took from the OLC. This is almost 15 years ago, and you can hear that little, as we take the ball out of the socket, that was the seal. And this was when we were first coming to understand that the seal mattered and that the labrum was a primary hip stabilizer. A lot of data has come out since then. We've seen that successful labral repair improves resistance to distraction by 92%. And a reconstruction can actually increase the resistance to distraction by 66%. So our surgical technique has evolved tremendously. Early on in treating FAI, many cases, both open and arthroscopic, involved acetabular rim trimming with labral resection. Later, we began to preserve the peripheral labrum and debride the base. We subsequently came to be able to perform labral refixation, which led to superior clinical outcomes. That was shown fairly early on in an article by Espinosa in 2006. This was with Reinhold Ganz and team, where they showed that labral refixations did better than labral resections. And then we adapted those techniques and understanding to arthroscopic treatment to be able to repair the labrum arthroscopically. And at this point have 5- and 10-year outcomes showing superior outcomes with labral repair. That said, repairing the labrum is not simple. And one of Ganz's quotes was, "The labrum sealing mechanisms are dependent on the fit of the labrum against the femoral head." So the evolution of our technique sort of centered around that principle. Some of the early techniques for repairing often left a labrum that was everted and bunched or not in contact with the femoral head, and thereby did not reproduce a suction seal. So we went through several iterations of labral repair techniques. One of the early ones that I was part of developing was labral base refixation, where we passed the suture instead of around the labrum, rather through the base of the labrum in a single or double vertical mattress structure. And this labral base refixation with the existing technology at the time allowed us to preserve the triangular shape and cross section of the labrum, restore the transitional zone between the cartilage and the labrum, and restore the suction seal, and to perform a labral repair without detachment. That gave way to the controlled tension anatomic repair technique as we came to have access to better technology with suture anchors that were knotless and tensionable. And this allows us to achieve consistent seal of the labrum against the femoral head, and to do so using inserter out selective tensioning of the repair stitches. So why not use knots? Saving ourselves from knots may save time, it may save from abrasion against the cartilage, and may save from providing a nidus for scar tissue. This is a labral repair of mine from about 15 years ago that I wasn't very happy with because in this picture, first of all, I have knots, but second, I have a labrum that is everted and pulled away from the femoral head. So when I take traction off, I saw a gap between the labrum and the femoral head, and there wasn't a whole lot that we could do about it at the time with the technology and techniques that we had. This is what we didn't want to achieve, and the labral base refixation and controlled tension anatomic techniques have given us ways of achieving much better anatomic repairs. One of the conundrums of some knotless anchors has been that the inserter itself can block the approximation of the tissue to the anchor. Because we have to tension it with the inserter in. So the advent of inserter out selective tensioning has given us a solve for that. Here's one example of inserter out selective tensioning with a knotless tensionable anchor. This allows for selective tensioning, preserving a consistent seal, saves surgical time, avoids risk of knot loosening, and maintains a low profile. There you see it there. So some tips and pearls for labral repair that we've learned over the years. And this is where I get into Edison's quote, I've not failed, I've just found 10,000 ways that won't work. In order to make it work, we need to start with meticulous rim preparation, and that means we need great visualization. We've described two particular views arthroscopically, the bird's eye view, which is from an extra-articular position, looking back on an extra on the capsular side of the labrum, and the upper deck view, which is seen in C here, image C, bottom left, where the scope is actually between the labrum and the capsule, and we can see the beak of bone that is attaching into the labrum. So we see the junction between bone and labrum. The bird's eye view is in image A, upper left here. So we want to establish a bleeding bed of bone at a minimum to create a biologic environment for labral repair. If we're doing a rim trimming, this is when we do it. If there's pincer type impingement and we need to reduce the contour of the rim, we do it here. And these views provide us with visualization for suture passage through the chondrolabral junction from the capsular side, so that we can be very accurate in where we place them. The drill holes should be performed under direct visualization as well, generally using the bird's eye view, sometimes the upper deck view. And when we start our drill hole from this view, but then we move to an intra-articular view, a central compartment view, to view the cartilage surface while drilling to make sure that we don't penetrate the surface. This technique allows for perfect anchor position and also maintenance of perfect cartilage without cartilage penetration. We want to sound the drill holes. This prevents anchor protrusion. So when drilling, particularly anteriorly where the bone is thin, near the iliopsoas fossa, we can run a guide wire down the drill sleeve before we place the anchor. So drill, then sound, then anchor. And this makes sure that the anchor hole has a bottom, the drill hole has a bottom, so we haven't penetrated out into the iliopsoas fossa or anywhere else that will cause soft tissue impingement. Suture passage. The suture should be passed through the chondrolabral junction, and the upper deck view and or bird's eye view can be used to find the entry point to do so. Sometimes labral repair is not possible because the labrum is calcified or shredded beyond repair, or we're doing a revision case where previous repair or debridement has failed. I've described those indications here. And in this particular study, which was a very important pivotal study for me personally, we compared labral reconstruction to segmental resections, because that's really the choice. If you have an irreparable labrum, you're either resecting it or you're reconstructing it. And we found that the reconstructions did a lot better. It was not a small difference, it was a big difference. And so it was a pivotal point for me that led us to consider labral reconstruction as the first choice for an irreparable labrum. We developed the technique called the knotless pull-through technique for circumferential reconstruction seen here. This starts with preparing the rim, placing all the knotless anchors. These are placed circumferentially around the rim. We then insert the tendon graft and pull the end of the graft out the posterolateral portal. So it comes through anteriorly and pulls out posteriorly. And then we fixate it in place with the pre-placed anchors working from anterior to posterior. So sequentially passing and cinching until we've completed the reconstruction, and then we amputate the excess graft at the completion. This allows us to have the perfect size graft every time because we don't actually size it until we finish the reconstruction. Here you see the finished product. This is the bird's eye view showing it from an extra-articular view. And then when we take traction off, you see the seal of the reconstruction against the femoral head, which is exactly what we're aiming for. Labral augmentation is an alternative technique that's come into existence in the last 5 years or so. This is perhaps indicated for irreparable tears with native labral circumferential fibers that are in good macroscopic condition but aren't big enough to produce a seal. This may be applicable for the hypoplastic labrum, like you see in the bottom right here, where you have a 2 millimeter ribbon of labrum that's just not going to produce a seal no matter what repair you do, but it doesn't necessarily need to be discarded. In terms of outcomes, we've tracked outcomes now over a decade and found significant improvement in patient-reported outcomes and high patient satisfaction at 2 years, 5 years, and 10 years. Here's the 5-year data and survivorship, PROs and survivorship, and the 10-year data is on its way out in print shortly. So some take-home points on the labrum from this journey that we've been through is the labrum is the primary stabilizer, a primary stabilizer of the hip. Current technique for repair is typically the controlled tension anatomic technique. Knotless tensionable anchors allow us to perform a bone preserving and simplified technique, which is very reproducible. Tips include visualization, good rim prep, and a knotless anchor. And in the revision scenario, reconstructions and augmentations give us some tools in our toolbox that can be very valuable. So I'll move on to the next journey. The journey number 2 was femoroacetabular impingement, and specifically accuracy in treatment of femoroacetabular impingement. Michelangelo said, "I saw an angel trapped in a block of stone, so I chiseled until I set the angel free." That's more or less what we're doing when we are trying to sculpt a femoral head that is not round into a femoral head that is round, or an acetabulum that's not appropriate in shape into an appropriate shaped acetabulum. We have to see at our mind's eye what we want it to look like and take away bone until it looks like that. So this is not a basic technique. There are a lot of pitfalls to it. Both over resection and under resection have problems, which I'll point out. But our goal is sphericity. And the open surgeons knew this. This was fairly obvious going back 20, 25 years, where we used spherical templates when doing the open surgery and try to create a perfect sphere. Because if we're going to reshape it, that's the best shape that we know to aim for in a ball and socket situation. But in the arthroscopic scenario, it's actually much more difficult because we're not seeing the whole globe. We're not seeing the whole ball. We're only seeing a small part of it. And this is a little bit like looking at the contour of the earth from a view standing on the beach, where we're looking at the horizon. And we can't see that the earth is round because we're only seeing a small part of the horizon, a small part of the contour of the earth. That's the arthroscopic view. The fluoroscopic view is a lot like looking at the earth from the moon. Here we can see that the earth is round because we're seeing the entire globe. And when we look at the femoral head fluoroscopically, we can see the entire globe as well. And we can see what is round and what is not, and what we want to take away. But there's a caveat to this. This fluoroscopic view, just like the view of the earth from the moon, is actually not a 3D view. It's a 2D view. It's a 2D perspective of a 3D shape. So we need fluoro from many angles. When we see the earth from the moon, we don't know that the earth isn't an egg that we're looking at end on unless we allow the earth to rotate. And if the earth rotates and stays a perfect circle, then we know that it's a sphere. So that's how we use fluoro. We use fluoro from many angles to know that we've created a sphere. We know the labral seal is chondroprotective, but the labral seal cannot occur if we have under resection or over resection. So under resection results in residual impingement. Over resection disrupts that labral seal. And you see in the images on the right where you have a disrupted seal. So our goal then is the perfectly spherical femoroplasty. And this I would call surgical sculpture. If we have under resection, we see this in schematic images here that Martin Beck first created. They've been adapted since then. So this is a little animation of cam type impingement. And then if we have over resection and we break the seal, Here's a schematic of over-resection. The labrum is now no longer in contact as soon as the patient flexes their hip or sits down, and we lose the seal that we worked so hard to create with our labral repair or reconstruction. Here's a short video showing an over-resection. So you can see we've got a great labral repair, but there's been a previous over-resection and a previous surgery. This was a revision surgery. So as soon as that over-resection enters the joint, poof, the seal is broken. You see a rush of fluid, and now the hip itself actually subluxes. The femoral head falls out of the socket because we've broken the seal. So a lot of attention has gone to under-resection, but I would argue that over-resection may actually be a worse problem than under-resection, and therefore we should be cautious in our approach to resections. So that was the subject of this very article, where we published on the search for the spherical femoroplasty, saying that CAM over-resection leads to inferior functional scores before and after revision hip arthroscopic surgery. So again, I would emphasize that if we are approaching CAM resections, we should approach them cautiously. We want to get a perfectly spherical femoroplasty, and if we're going to err, I would err on the side of under-resection rather than over-resection. We also want to consider the unique demands of the patient. So here are 4 very different kinds of athletes that have been treated at American Hip Institute. My favorite is the bottom left one. This was in the early days of MMA at UFC 2. Our patient is the one on top, not the bottom, who was a 200-pound guy fighting a 600-pound guy, and actually won. But as you might expect, he's had some tolls that were taken on his body over the years. So 4 different kinds of athletes, 4 different motions required in their hips, and we want to understand the motion that's required in an individual sport to understand what we need to do. So in conclusion, we've learned in this journey to aim for a perfect sphere. We've learned it's technically challenging, but can be done. We need to use all our tools. We need to use pre-op planning, intraoperative multidimensional fluoroscopy, and in the future, I hope that we will also use robotics, navigation, and/or virtual reality. So the final journey, the last journey I'll take you through was recognition and treatment of hip instability. Now, wait a second. I was taught in my residency that the hip was an inherently stable joint. I think that has probably changed, and you may not be learning it the same way I did. Certainly, we've come to understand that it is not necessarily inherently stable, but although hip instability exists, it is different from shoulder instability. Instead of dislocations, it's micro-instability. Instead of traumatic, it's usually chronic. Instead of acquired, it's usually congenital or developmental. And instead of dynamic, it's often static. So we start with physical exam, as always. Supine apprehension test and anterior instability test. There are a variety of ways of doing this. We always look for Baton's tests. I'll get to those. And we want to evaluate the radiographic situation. So we want to look at the lateral center edge angle, look at the tonus angle, understand the acetabular coverage, the femoral version, femoral anteversion, and any bony factors that may predispose the patient to instability. If we come to understand that the patient does have instability and they're not somebody who's indicated for a PAO, I'm going to spare you a conversation on PAOs for today. PAOs are the gold standard for dysplastic hips. But assuming it's not a frankly dysplastic hip, we didn't have a really great alternative for these patients 15 years ago, and they did badly with arthroscopies that involved capsulotomies and labral debridements. So we developed this technique for capsular plication with inferior shift, and actually Dr. Giordano and I were co-authors on this particular paper, which was, to my knowledge, the first description of the technique and biomechanical rationale for capsular plication with inferior shift. And it took advantage of the portal-to-portal capsulotomy, which we make routinely in arthroscopy. And what we want to do is this. We want to imbricate the capsule and perform a shift that accentuates the screw-home mechanism of the spiral of the capsule. We did this by placing sutures in a way that had bite sizes that would imbricate and angulation of obliquity that would cause a capsular shift, which eventually looks like this. So we piloted this technique in a group of at-risk patients. These were patients with borderline hip dysplasia and labral tears, and found that with arthroscopic capsular plication and labral preservation, we could achieve very consistent positive outcomes in a patient population that presented a challenging problem. So in terms of what's next, there's a lot ahead of us. We are not done. Those are our three journeys. But the questions that I hope to answer in the next decade: how much arthritis is too much for hip preservation, and how can we predict that? What do we do if hip arthroscopy fails, and how do we handle the failed hip arthroscopy? How can we shorten the learning curve so that all of you and others like you can learn to do successful hip preservation surgery faster? In terms of procedures, the gluteus medius repair is still evolving. We've developed the suture staple technique, and I'm sure there'll be continued refinements. And ligamentum teres reconstruction, we've developed the technique for it, still really figuring out who needs that. So it's the proverbial procedure looking for an indication. We think there is one, but it needs further refinement. And then capsular reconstruction, another technique that's still really in the process of being developed and refined as I see it. So why do research? Do research because this is a new field. I have done research in my career because we found ourselves in a field that was being birthed. And when we are undergoing the birth of a field, research is an absolute requirement in order to prove what's working and what's not. And to facilitate what has been this paradigm shift or way of looking at something differently, where we look at hip preservation as its own field, research has been a critical part of what we've done over the last couple decades. So I would submit to you then that hip preservation is in fact now a new subspecialty. It has undergone a fascinating evolution of understanding, and it is difficult without dedicated specialized team and dedicated training, but there's a great opportunity to help people if we can master this field. That has been the core of our mission at American Hip Institute. We've had some incredible people who have been a part of this team and this mission. I'd like to tip my hat to many of them. The research and innovation that we've done over the last couple of decades has very much been a team effort that has involved many of our trainees, our fellows specifically, as well as our research analysts and statisticians and research teams. So truly a team effort over the course of many, many years. Our overarching goal at American Hip Institute Research Foundation is to help patients. And the way that we seek to help patients involves all of these spokes around this wheel, including innovation, our fellowship training, patient education, outcomes research, and acting as a surgeon resource. And I'll highlight that because for all of you who are in training, please do feel welcome to American Hip Institute Research Foundation's website, which is intended as an educational resource for surgeons specifically. So there's a lot of material there, a lot of videos you can watch on technique and pathology. A word on our fellowship. The American Hip Institute Fellowship is a comprehensive hip fellowship in hip preservation and all aspects of hip surgery, including hip arthroscopy, advanced techniques, open hip preservation, osteotomies, robotics, anterior approach THA, and hip resurfacing. It is most commonly done as a second fellowship after sports or reconstruction fellowship for those who have a specific interest in making a career in hip preservation. So in summary, one more quote. Atlas said to Zeus, "I ask not for lighter burdens, but for broader shoulders." And as we've gone through the birth of this field, we have discovered that we can have broader shoulders with a variety of complex techniques, utilizing technology available to us by knowing what is in your quiver, including labral repairs, labral reconstructions, labral augmentations. All of these things have given us broader shoulders and ability to treat more things as we've learned to diagnose those same things. Choose your cases wisely, consider following your outcomes when you get into practice, and certainly consider additional training before you get into practice. And lastly, wrapping up on mentorship, you are very lucky to have the mentors that you have at University of Rochester, Dr. Giordano and all the others, and do think of that as a two-way street. Do think of how you can help them and what you can do for them, and it will be returned in kind if you earn their mentorship. So with that, I will conclude, and I think we have left at least a little bit of time for questions. And thank you once again, Brian and everyone else at University of Rochester for welcoming me today.
Thanks, Ben. That was a tremendous talk, and you know, every time I see you talk about this stuff and go through it in aggregate, it's even more impressive to see what you've been able to achieve and offer, you know, the world of hip preservation, really, you know, pushing forward the frontiers of what we can do and making it easier for the rest of us mere mortals. You know, I guess the question I'd ask is, you referenced Frank Jobe a lot, and you know, we've got a bunch of KJ alumni in the audience here, and you know, in looking at baseball in particular, there's a lot of literature coming out on prevention, pitch counts, and, you know, technical adaptations, and, you know, a lot of our talks in hip preservation tend to be technical, but I'm always wondering to myself, you know, are there things that we can be doing preventatively with the morphology, with the shape of the joint, to prevent that from becoming symptomatic? And I wonder if you could share some of the insights too on how you've been able to, you know, think about this, the prevention of hip pathology and some of the non-operative care.
Yeah, that's a fantastic question, and we are just absolute runts as far as figuring out prevention in the hip. You know, I think baseball is really specific. The motions in baseball don't really occur in other sports, and they don't occur in the activities of daily living. Whereas a lot of the hip motions that get our hips into trouble do occur in activities of daily living. They occur across a variety of sports. So just as an example, if you have a hockey player who develops cam impingement during their teenage years, and then let's say that we want to prevent them getting hip problems, so they quit hockey altogether, but they still have cam impingement, and probably that cam impingement is a result of the hockey during their growth years. And that cam impingement is going to come into play every time they sit down. It's going to come into play certainly every time they do a squat if they go to the gym. So it's going to affect them across a variety of activities. So then maybe our preventative thinking in the hip needs to start earlier, because so many of the problems we treat are developmental. And if we can start to think of what happens during the growth years that creates malformed hips, cam impingement being one example, dysplasia being another. My daughter was involved in rhythmic gymnastics from the time she was about 8 years old. If you're not familiar with rhythmic gymnastics, it's not the one on the bars and stuff. It's the one with the ribbons and the balls, where it's all on the floor, but they must do splits and oversplits. So if you don't know what an oversplit is like doing the splits, but you put your front leg on a chair so it's even past the splits. And this is a requirement to be able to do rhythmic gymnastics. So I'm seeing my 8-year-old, 10-year-old daughter doing oversplits, and I'm pulling my hair out as a hip surgeon, thinking, you know, this is going to affect the development of her hips. And ultimately we pulled her out of it because I felt it just wasn't worth the risk. I felt it would inevitably affect the development of her hips, and I didn't want to do that. So she's found alternate activities. Now, we can't tell every parent of every hockey player to pull their kid out of hockey at age 10 until they're finished growing, because those are the years when we learn to play a sport. But is there a way that we can prevent these developmental problems? We kind of know when they occur in life. We kind of know which activities bring them on, and maybe we can learn ways of preventing those things.
Ben, thanks for doing this for us. You know, sometimes when I've been in orthopedics long enough that hip preservation didn't exist, and I'm a spine person. And of course, spine has had its own travails of inventing surgeries that made a lot of sense to us and yet didn't always benefit our patients. And I think the thing that's lacking in spine surgery is some kind of quantitative diagnostic test for things around back pain. And I just wonder if there's anything that you're aware of that's exciting on the horizon with regard to hip pain, new imaging techniques, things that are going to be influential in our residents' future.
Yeah, I think spine and hip actually suffer from some of the same challenges, which is that there are just a lot of nerves in the area, and there's a lot of cross innervation between the hip and the spine and other things. So, pain in the thigh, that can be a lot of different things. That can be a spine problem. It can be a hip problem. It can be a groin pull. It can be a variety of things. So the diagnosis in both areas has been more challenging than, say, in the knee or the foot or the hand. As you get further out in the extremities, there's less cross innervation, and the diagnosis is easier. So, in terms of diagnosis, I think there's one major thing that we've had in the hip that has been a difference maker that pops to mind, which is the intra-articular diagnostic injection. And, a lidocaine test injection where we inject lidocaine into the hip joint, and within 30 minutes, we should be able to tell whether it numbed their pain or it didn't. And that's been a really powerful test to be able to figure out if the pain is actually coming from the hip or not. But I use that a lot today. We all use that a lot in the field, I think, when we're not sure if it's a hip problem or a spine problem, or if it's coming from the labral tear or it's just a groin pull. That intra-articular lidocaine test has been very helpful. Other things coming down the pike in the future, I've got a bit of a fascination with personalized medicine and predictive modeling, where we can plug patient factors and disease factors into a model and predict how well they will do with various interventions, whether hip arthroscopy or other. And I think that there's a future for us in predictive modeling to help us do the best procedures on the patients who will benefit from them the most, and avoid them on those who will benefit from them less.
Maybe as a follow-up, there's nature and there's nurture. And many people have, family pets, dogs that are prone to hip dysplasia and hip problems. What do you think? You talked about sports and talked about your own personal family experience with rhythmic gymnastics. How much of this is nature and how much of it is nurture?
Well, probably it's a really salient question, and probably we don't know all the answers. We've identified in dysplasia that it's been known for a long time that firstborns, people with family history, women, people who are breech, those are all risk factors for dysplasia, right? And those all start before you're born. So I guess we'll call those nature. In terms of nurture, it's been much more recent that we've come to understand that doing splits repeatedly is going to more likely make you continue to be dysplastic. Playing hockey is going to more likely make you develop a CAM lesion. And we're just really scratching the surface of understanding how those things come to be, but we have started to see the associations. So I guess I don't have a great answer to your question, because it's probably both. And in some cases, it may be more one than the other. But I hope that we'll better understand how and exactly when those things occur, particularly in the nurture ones, since we can't do a whole lot about the nature ones, the nurture being modifiable. If we can understand better the when and the how, we might be able to modify kids' activities to help change the natural course.
Ben, this is Ilya Voloshin. I'm a shoulder guy here at University of Rochester. Wanted to ask you a quick question. It's a little bit personal one. So my son plays a sport called squash, and it was actually entered into LA 28 Olympics coming up, and about 50% of pro players that I know in squash ended up having a hip resurfacing or hip replacement. And I'm just wondering, is there prevalent studies in hip literature as to what sports produce most injuries? And you mentioned gymnastics and hockey. And is it just based on the personal experiences of hip surgeons, or there were prevalent studies that looked at that and defined those sports are the ones that highest at risk?
Yeah, that's a great question. There are some prevalent studies, particularly in the risk of arthroplasty over a lifetime. Just broad brushstrokes, a male who was an athlete as a child is about 6 to 7 times more likely to have a hip arthroplasty than a male who was never an athlete. Your question is more specific than that to the types of sports, and the data that I know of hasn't drilled as far down as figuring out, like, comparing squash to football or tennis or something else. But anecdotally, I certainly have seen it across hip pathology across a variety of sports, even young in life. If we common sense this, I think if we were basically built and evolved to walk and maybe run, right? Those are kind of straight line things. All the things that involve repetitive cutting, jumping, hard pivoting, squash being one of those, we probably didn't evolve to do those things, and they place a lot of load on the hip and a lot of torque on the hip. So it's my anecdotal experience that those things put a lot of strain on the hip and probably increase our risk of hip problems. Basketball was my sport, obviously, and basketball has some unique movements that are a little analogous to squash in that you are very often abducted at the hip. There's a lot of lateral motion. So a lot of flexion, abduction, and lateral motion. I'm sure there's some differences as well. I've never played squash, but I do think those things put a lot of strain on the hip.
So basically, we pick out poison. We either walk straight at 90-degree angles, but then the life is boring, or we take some risk and play some sports and then deal with consequences.
Right, and as long as that keeps happening, I guess we'll all have a job.
Yeah. All right. Thank you. Great talk.
Thank you.
Well, thanks. I think people are wrapping it up and heading to the OR. I know you have to get to your clinic, and again, thanks so much for sharing your time with us this morning. I wish it was in person so that we could show you all the glory of Rochester, New York. But maybe we'll figure out another time to do it. So thanks again, Ben.
Great. Thanks a lot for having me. Take care, guys.
Take care.